So our next panel, our first panel for today really, is the Patient Partnership Panel, the Connecting Communities. And I'm very pleased to welcome Bennet Nemser as the moderator of today's session. He'll introduce the rest of the panelists.
Thank you, guys. Great to be here. I'd like, just because I think everyone else did, I'd like to thank the Stephen and Alexandra Cohen Foundation for hiring me, I guess would be like what I want to thank them for. But I'd also just like to actually have the panelists, why don't you guys come up? I don't need to call you out each individually. But really, I really took this opportunity from Savi to have a panel on really understanding that patient clinician interaction, right? We've talked a little bit about it today and all the challenges that go along with it. So it really, to me, want to understand sort of why is it so hard, right? Why is there so much difficulty around it? What works, what doesn't work in terms of strategies to communicate correctly or properly, appropriately, both from the clinician side and then the patient side, and then what sort of strategies can you use to make it better over time? So I'd like each of the panelists maybe to give a brief introduction for themselves, and why don't we start here with James? You know, give a little minute about yourself and about your maybe experiences with Lyme and anything else you wanna mention.
Yeah, sure. Is this on? Can everybody hear me? Yep. So my name is James Bruzzese. I'm currently a medical student at the CUNY School of Medicine. My story starts about 3 years ago. My little sister fell acutely ill with Lyme and lost her ability to walk. Many of you may actually know her. She was blessed by the Pope at the airport when he came to New York 3 years ago, and she's got a lot of media attention. Her diagnosis actually led my entire family to find out that we all suffer Lyme, including myself. And it's been a very unique experience, and it's put my family through the ringer. And being a medical student at the same time has been very interesting, especially seeing what's taught in medical schools about Lyme disease. And knowing what I know from my personal experience and from my family's experience. And I guess, during this, we'll talk a little bit more about that. Yeah, so that's me.
Yeah, Steve?
My name is Stephen Phillips, and I'm a physician. I'm an internist from Wilton, Connecticut. I've been in practice for 22 years. I started my interest in Lyme in residency at Yale, doing bench research on the bacteria that causes Lyme disease. Later to go on to find out that my father was suffering from undiagnosed Lyme for over 20 years, his diagnosis having been missed by the best cardiologists at all the major teaching hospitals in New York City, and having had his illness progress to the point of very severe heart failure, such that he was slated to get a heart transplant. And his survival without the heart transplant was, on average, 6 months at that time. So that was over 20 years ago. And I brought up the topic of Lyme to his cardiologist, and I got the eye roll. And he would not test him or treat him. His test was negative. I had been on doxycycline for 3 years at that point for acne, and I never had bad acne. And I saw this real disconnect that I was on long-term doxycycline for zits, and yet this very serious thing that my dad had, which could have been a manifestation from Lyme and ultimately turned out to be a manifestation of Lyme, they wouldn't entertain the evaluation. So I ended up treating him. He ended up responding. His heart function normalized completely, and he's now 86 and never needed the heart transplant. At that point, I focused my career solely on the care and management of patients with these complex illnesses. And I've since gone on to publish a number of articles in the peer-reviewed medical literature and have been instrumental in passing laws about Lyme disease throughout the states of New England. I guess that's my cue to shut up. So.
Straight from the top, Steve, straight from the top. You've said enough.
Okay.
You have enough blogs, you have
like
enough...
It's like the Oscars when they play the music. Okay, that's it.
All right, where are we going against you next? Samantha.
My name is Samantha Sexton. I have had Lyme for 22 years. It took until I was about 18 to receive the diagnosis of chronic Lyme. And from that point on, I've been continuously treated. I've seen over 60 doctors and practitioners in the last 10 years. And I had no improvement in any symptoms during that time. I've tried countless protocols and different treatments, and nothing has worked. Until this last summer, I went to the St. George Clinic in Germany for extreme whole body hyperthermia. And I can say, honestly, for the first time in my entire life, I'm noticing an improvement in symptoms. It's slow, but it's happening, so it's the only reason I'm here to speak to you today, because I'm feeling a little bit better. And really, the thing that's so important to me is I've met so many patients who have the same story as I do, and they are losing their homes because all their money is going to their Lyme treatment. Their families have abandoned them because they think they're crazy, and I understand them. I know what this disease feels like. I couldn't have gotten through it without my family. It's very lonely, and I'm here today to speak for them.
Hello, I'm Phyllis Bedford. I'm the executive director and one of the co-founders of LymeLight Foundation. And we have a whole lot of people like you. So what we do is we provide treatment grants for children and young adults suffering with Lyme disease who cannot afford the care. And we are the only Lyme foundation that is solely focused on providing treatment grants. Our grants are up to $10,000, and they are for individuals up to age 25. And currently, we are only able to reach 60% of those who apply. And it's need-based. So it breaks our heart, honestly, every board meeting to have to say no to anybody, because everyone is so deserving. And it's, like you said, a very lonely and isolating journey, and a lot of these people don't have support. So to date, with the Cohen support and the support of others, we've been able to help, since our inception in 2011, I should say that, we have helped 598 individuals in 46 states, and we have given out over $3.6 million in treatment grants. Wow, thank you. I also come from the perspective of being a Lyme patient, a caregiver. Our daughter was very, very sick, which is what started our family on this whole odyssey, and then also running a foundation with about 600 sick individuals. So I'm really happy to be here and delighted. Welcome for your first ever patient day. And I also am grateful that you hired Ben. You're wonderful.
I didn't pay her for that.
My turn?
Yes, please.
Am I on? Okay.
Yeah.
So my name's Patricia DeLaMora. I'm a pediatric infectious disease physician at Cornell. I do know some of the people in this audience from previous iterations of this conference. I was invited to sort of balance out and give an academic perspective on the treatment of Lyme disease. I do not treat adults. I only treat children who have sort of a different flavor than many of their adult counterparts sometimes. This is not all I do. I am not solely a Lyme disease physician. I see inpatients in the hospital with all sorts of infections, but a bulk of my outpatient practice is Lyme disease. And I see children from all over the tri-state area, eastern seaboard. There's unfortunately not a lot of pediatric infectious disease physicians who take insurance who are willing to see patients with Lyme disease.
Great, thank you guys. Now, I would like to say for myself, I also come into this journey as a caregiver for my wife who's battled tick-borne disease for about 4 years, almost 5 years now. She's here with us today. She's the one you can see on her face that says, "I'm going to kill you this evening," for pointing me out. I tell you this just so to give a understanding and be like-minded with them, but also so that you guys are gentle with me, make me look good in front of my wife. Only softball questions for me. All the hardball questions will be for these guys. So I guess without further ado, I really, again, like to get better understanding, unpacking a little bit around this patient-provider partnership and understanding sort of what are the dilemmas, what are the challenges around that. So maybe I'll kick it off with Phyllis, right? Phyllis, you have a very bird's eye view. You're seeing these relationships across hundreds of patients. In your view, what's sort of some of the biggest challenges that patients are facing with trying to get the care that they need or they think they need?
Well, I think a lot of what I was going to say has already been said this morning. And mainly, if you think of it, the main thing is getting the diagnosis, right? I I mean, how many, I know I'm kind of preaching to the choir here, but having patients be bounced around to all doctor to doctor to doctor and, 25, 30 doctors is not unusual. And, think what that does for a person. You've gone to how many doctors and you're told there is nothing wrong. And I just want to think of how about the person that didn't get to that 30th doctor? How all the people that are out there stuck at doctor 29 that hasn't seen the 30th doctor that's diagnosed them. So I think the first big problem is getting the diagnosis. The second problem or the second issue is the testing, which has been well talked about today. But we see so many people in our population that got the wrong test, got inconclusive testing, the wrong person saw the results of their test. That is a big hurdle. And I was talking earlier, we really have to get our primary care physicians just knowledgeable, because how many people could we wouldn't have chronic cases or not as many chronic cases is at the get-go. They were given the proper medication and care and treatment. And I also think an issue is when you get to your LLMD or naturopathic doctor, that one size doesn't fit all, right? I mean, so many other diseases are linear. I mean, you get it, and these are the steps you go through. It's just not true with Lyme disease, and that's really hard for a patient. You finally get the diagnosis, right? And then what? What path do I go? And I think that's hard for the practitioner, and I think it's also hard for the patient. So I think those are probably the biggest. I just want to end sort of on a powerful or a positive, is that as Lyme patients, we have an opportunity to take control of this, though, right? If we educate ourselves and we really partner with our physicians, it's our bodies, and we know which direction we want to go, or we could try. Did you try antibiotics? Do you try antimicrobials? Do you try this? But we can partner. And other diseases, you don't partner, right, as much. This is what you do. It's a bit of ownership, and that's the positive. And I have seen our grant recipients become so empowered by this. When you tackle Lyme, and you can go up against Lyme, you can go up against anything. And that's really the positive when you get on the other side.
Great, thank you. And maybe over to Samantha, because I think it kind of keys into some of your experience. It sounds like you've been sort of run the gamut. You've been to 60 doctors. Can you give us any sort of examples on sort of some of the where your expectations sort of weren't met in some way, or had some sort of challenges, and what did you learn from that process?
Yeah, absolutely. I think besides not feeling better after going to 60 different doctors, my expectations weren't met when I realized that some of these appointments were more like an interrogation. I was being questioned. Are you sure that's what you're feeling? Yes, this was really happening. It wasn't in my head. There were very few doctors that believed me from the beginning. It was so frustrating to be told that this is going on in your head. This isn't physical. What I learned from it really was that I had to become my own doctor. I had to teach myself, what was the best treatment for me. Really to go off what Phyllis said, you have to partner with your doctor. You have to take an active role in your own healing. You can't just sit by and just say, yes, I'll do whatever you say. You have to know what's right for you. And unfortunately, it took me a long time to learn that, but I think it's helpful for the doctors as well. If you are more active in your own healing, they know what you are willing to try and what might work and what might not, and it's a real partnership.
No, that's great. Thank you. James, what do you think about that? I know we've traded stories about belief in the patient, and I'm kind of curious what your thoughts are there, and then maybe if you can reflect on sort of your time in medical school and how that maybe interacts.
Sure. So through my experience, I will definitely say, and sure this is a generalization, but there is hostility out there against patients from doctors. There was a doctor at Columbia Presbyterian who was so frustrated with my sister's case because she couldn't figure out what was wrong. She made a physical therapist drop my sister on the floor on purpose to see if she would save herself and walk, because her theory was an 11-year-old child in the middle of the summer was faking paralysis. Actually at Mount Sinai Medical Center, they would steal the wheelchair away from my sister's room to see if when she needed to go to the bathroom, she'd get up and run to the bathroom, use the bathroom, and then run back to her bed. which then required me or my father to carry Julia's limp body from the bed to the bathroom every time she needed to use it. There's, if I look at medical school, they teach tunnel vision. That's curriculum-wise, that's how they teach it. Test-wise, that's how they teach it. If I get a test question, right, and all standardized tests are going to be the same, whether you're in medical school, whether it's the SAT. There's patterns, right? So you look for clues in questions. So if I get a question that's like, okay, patient has experienced toe pain last week, now comes in with a swollen red joint and drinks alcohol, I'm going to think gout. Because those specific clues, those specific things, I know the question's going to gout, right? But if I see that in the real world, is the answer going to be gout? Is there no further investigation that is warranted there? No, there is. That's not that's not how that's going to be in the real world. So I think that the disconnect between doctor and patient, I mean, first of all, definitely in education, there's a disconnect. And I think that there's also this, what you were talking about with it's not the patient's fault. If I go to a hospital and I have something that's a little difficult to figure out, that I might not test positive on, the routine blood tests that they're going to run, or if, I'm not within their scope of practice and they don't know what's wrong with me, why am I going to begin to get criminalized? So I think that there's a problem in our medical society. And I think that doctors need to be able to see out of that box. I think there needs to be a lot of change when it comes to medical school. I think that it needs to be taught that, it's not so cut and dry. It's not with, like Dr. Horowitz was talking about before, where it's, one disease process, one cure, one treatment. It's not like that. You're going to have multiple things affected, multiple systems affected, and I think that that's what's lacking.
Thank you. Why don't I shift over to the doctors that have gone through medical school? What are your reflections on that?
I mean, this is a broad question to try and address, but there are problems with access to care, both for initial diagnosis, believe it or not, and for certainly chronic disease manifestations. I was just shown a picture of a nearly perfect stereotypical erythema migrans when I was coming in from somebody I know from Connecticut, and this patient's doctor refused antibiotics, had given the antibiotics and then stopped the antibiotics because the Lyme serologist came back negative. And by any most conservative measure, even by IDSA standards, for example, that person should be treated. So physician witnessed erythema migrans. The doctor thought it was a Lyme rash. The test came back negative, and the doctor is withdrawing treatment. And that's a departure even from the most conservative standard of care. So we see, mistakes even on that end. And then once people get a month of antibiotics, the facts unfortunately say that a very significant proportion of patients go on to develop chronic symptoms. And there are studies that show 15 to 20%, and there are studies that show much more. Johns Hopkins had a study where 39% of patients had failed therapy. Danbury Hospital did a study at 1 year, 61% of patients are chronically symptomatic despite a standard course of 1 month of antibiotics. So the question is what to do with these patients. After having been in practice for 20 years and having treated 22,000 patients, I have seen what I can only describe as horror shows, too many to go into, but people, as a rule, being disrespected, disenfranchised, and basically cast aside. I have patients who have developed post-traumatic stress disorder from having gone through their experiences with their doctors. I, for example, have a patient who was a child when this all began, probably around Julia's age. Her parents were told to ignore her, that she was just seeking attention, and she also had to be carried from room to room, limp body, and came close to death, really. And happy to say she's doing well now as an adult. But so I do think that getting at doctors when they're young is critical. Getting into medical schools, there is this kind of stereotype that, old dog, new tricks. It's completely true. It's one of the rare stereotypes that seems to bear out over and over again, that doctors learn when they're young, and it's very easy to teach. They're good learners when they're young, and once they're older, they really don't take in new information very well. It's this thing, it's a pervasive bias that we all have as humans called confirmation bias, where we scan the data and look for information that conforms to our preformed narrative. And that's what we take in. And you only take in the stuff that disagrees with your preformed narrative when you have an emotional connection, when you have a loved one or yourself becomes involved. And I've said this at other public events. I've treated personally over 100 doctors with chronic Lyme, and only 3 of them will treat Lyme patients. So what does that say? That says that nobody wants to stick their neck out. Nobody wants to go against convention. Nobody wants to be the person that makes a stink. We all want to follow, it's like that expression, sheeple. And we're kind of, I think, inherently wired that way. I always think you have to have a personality disorder, like against authority, to be a Lyme doctor. And I'm glad I have that.
Likewise, we are too. Dr. DeLaMora, I could see you were going to jump in. Any your thoughts on sort of like
I feel like, again, as I'm afraid, the sacrificial lamb. So I do teach medical students and residents every day. I've been at Cornell for 20 years. They are so tired of hearing me talk about Lyme disease. I have made CME for pediatricians and other primary care doctors that is available online. I think there is a lot of controversy between ILADS and IDSA, but that story of the person not recognizing an erythema migrans rash and doing serology, if anyone left our residency doing that, I would hunt them down and throat punch them, because we have talked about this so many times that that's not how you do this. I think I hear the stories that you're telling me in my clinic over and over and over and over and over again. And Dr. Fell and I were just talking in the hallway before. I think there is a very big tendency to say that what is happening to you is not happening to you. And the conversation I have with my residents, who are all mandated to listen to me yammer to them for a month a year, that is not the answer. I can't tell you that you can't get out of bed. No, yes, you can. Well, if you can't, you can't. I mean, that's not for me to tell you yes or no. I don't think telling you it's not an infection, thank you for coming, take care, bye-bye, is at all ever the right thing to do. I know it happens. I don't know how to, I can't be, the spokesperson for all the doctors in the world who work at an academic center. But I can tell you that there is some hope. I know that you're speaking about the old dogs learning new tricks. Their largest pediatric practice in New York City has all watched that CME. And they all email me every fall, hey, can we rewatch it? Where's that link? Can you send it again? And in there I talk about, you can have a negative Western blot and you can still have Lyme disease. Please don't send it during early disease. Please think about it if you have XYZ. Not everyone gets better. Even for children, the rates of chronic illness are lower than they are for adults, according to literature. But it doesn't mean you can ignore that small percentage and tell them, oh, you should be in the 90%. So bye. You need to acknowledge that these things are happening and deal with those consequences. I think what to do with them is a big source of controversy. But I think the agreement needs to be, it can't be, sorry, not my problem, and closing the door in someone's face. So it's not everywhere we teach it. Come to Cornell.
I would love to come to Cornell. I'd love to speak at Cornell.
By the way, speaking of speaking, if you have questions, please text them in. You see the text message over there. I'll start reading out questions from folks. I guess one question, and I'm trying to get it's hard to, there's a lot of uncertainty around Lyme, right, in terms of treatment and how to get people better. I mean, you take Samantha's case, for example. You've been to 60 doctors. Some of them were probably following IDSA, some were probably following ILADS, and not all of them work, right? So, does open question to anyone, should the patient have the right to access these other therapies outside of IDSA, and really what are the pros and cons of that decision? Apparently our panel does not like open-ended questions.
I think the word right is hard, right? The right to anything is a difficult one. I think knowing the pros and cons of what you're asking for and seeing, the evidence behind it and being able to access that evidence behind what's being offered to you is important.
Well, and I also think that patient education plays a very important role in that. And that's why it's a shame that, we do have this separation of two camps. When this happened with my sister, I had to let my dean know at my school just in case I had to miss anything. And when I was talking to him, he was like, whoa, stop right there. I teach Lyme disease here, and I don't know any of this. And I was like, oh, well, you're part of the problem. And
You failed that semester, right?
No, they're very open. I'm actually very happy with my medical school. I'm working with them right now to change the curriculum because, he looked at the issue. He did his own research into it. He found out about the disagreements and the controversies, and he was like, as rising doctors, you guys should know both sides. You should know what's going on. We don't have to take a bias here. We don't have to take a side. There's obviously big discrepancies, and you guys should know, because when you're doctors, you should educate your patients. You should tell them, look, this is what's going on in the Lyme world. I suspect you have Lyme. This is what IDSA believes. This is what ELIDS believes. These are the controversies. How would you like to proceed? I think that it comes down to that basic conversation.
I think it's interesting that, when this is the complaint that I get from lots of patients, that when they go to some IDSA doctors, certainly not all, they're not made aware of an ILADS perspective. It's never brought up that, hey, there's another standard of care out there and we can educate you about both standards and you can make an informed decision. When people come into my office, it's ad nauseum, the education that we give about the two standards of care. They sign 10 forms. We give them copies of the forms. There are forms they can download from the website. It's a lot of education to say, look, if you want to go after all this, pursue the short-term antibiotic, standard of care, this is where you go. And they're made aware that they're the final arbiters in their health care. So very pro-patient autonomy, very pro-education to the point where the patient themselves can make an informed consent. There is so much strain, heterogeneity with these infections. Lyme is not Lyme is not Lyme. I remember when I was a resident, I had two 19-year-old kids, male patients, come in 2 days apart with the exact same presentation. They both had multiple erythema migrans and both had heart block, both required temporary pacemakers, very stereotypical Lyme cases. The first one had this massive Herxham reaction with like 104 fever. And I had like a family meeting with the second one saying it's going to be horrible, we're going to get through this. And nothing happened. I was so embarrassed. And I realized that they looked identical on paper. They looked like the same person. And they reacted completely differently to antibiotics. And so any doctor that tells you this is going to work because this is your diagnosis, we're going to call this Lyme, they're kind of full of baloney. I mean, it boils down, unfortunately, to a bit of trial and error. And I always say, the fair shake and the expiration date. You give a treatment enough time that it should work if it were to work, and then you cut your losses. Because I see so many patients come in that have been on 9 months of doxycycline that's not working. And I'm like, why did they continue after the second month? I don't get it. And they said, no, give it time. Well, So take-home messages, patient autonomy, informed consent, education. And if somebody comes in and asks me for something that I'm not comfortable with, I'll say, look, I'm not comfortable with that, and I would say no. But if they have a reasonable request to a range of treatments that I use anyway, patient choice plays a very large role in my decision-making process, and that's how we play it.
Yeah, I completely agree. And I feel like as a patient, making my own decisions about my health was huge. But the other side of it was that I wasn't feeling well enough to make these decisions. I couldn't think clearly. I still can't. I'm forgetting what we're all saying as we're saying it. The brain fog is terrible. So, that was another huge issue. And so many of the patients that I talked to felt the same way, that, as much as I want to take control over my own health, I really needed to lean on my doctor because I didn't go to medical school and I don't know the right answer. But, I can't make these decisions by myself.
Of course. No, not saying make your decisions by yourself, right. But most, we encourage people to come with like a health advocate, whether it's a family member, a close friend, loved one. If patients come in, we have patients come in that they're so encephalopathic, so kind of obtunded that they can't make any decisions for themselves. And of course, it's case-by-case kind of basis. But many patients do feel empowered by the ability to make these, you say, I'm going to give you one of two options here, of the two options that I think is best for you. And I don't know which will work better. And out of the side effect profile, what sounds less objectionable or more palatable to you? And that's kind of how we play it.
Phyllis?
I just want to jump in quickly. Interestingly, when we give our grant recipients up to $10,000, and they know they're going to have this money. Suddenly they're empowered. What am I going to do with my $10,000? And that's really interesting, and it's had an interesting effect of what treatment am I going to discuss with my doctor that I can afford with this money, and what is it, I'm not going to be married to any one treatment, right? I only have this amount of money. And it's been so interesting, the feedback we've gotten about how empowering that was to help the family make the decision. And then we have an exit survey that's anonymous when they finish their grant to say, first of all, did the grant make a difference? And then secondly, what made a difference? Like, what did you pursue? And we just generalized it. Like, was it more allopathic medicine? Was it more alternative medicine? Was it an integrative approach? And interestingly, almost everyone is an integrative approach. It's not just one or the other. It's an integrative. I would say if it is one, it's almost always alternative medicine. And it's really interesting how some of these things we talked about, the oils, the herbs, the so forth, make a huge difference for Lyme patients, and they can afford it. So it's very interesting, and we didn't set out to have this information, but it's very interesting. And again, I go back to this empowerment. They feel involved. They feel that they are in control, which is very interesting.
That's great. And go on, James.
Yeah, I just wanted to say really quick, in answer to your question and to just bolster what Samantha said, because I totally relate to that as well. Bottom line is, doctors need to figure out what's going on. Mm-hmm. Really, that pressure shouldn't be put on the patient in any way at all. Because I walk in as a patient, what am I supposed to know? I'm coming there for help. You're the one who underwent all this training to help me. It's your job to help me, right? And if there's a discrepancy in the medical field, that shouldn't be on the patient's shoulders.
Well, kind of who said it was, though? People have to realize also that physicians are human beings, and what we learn in med school is one paragraph, and that one paragraph is incorrect about Lyme. So all the training that we get, except for at Cornell, which has excellent training. But, I was taught that, you treat with positive serologies, you treat for a month of doxycycline, or 3 weeks actually. If that is a bad clinical outcome, you do an LP, a spinal tap. Spinal tap is positive, you treat Rocephin. If the Rocephin doesn't resolve symptoms, it's post-Lyme syndrome, end of story. And like I said, it's not, I don't think, unfortunately, a reasonable expectation for doctors to have all the answers. And I'm certainly by no means advocating for having the patients make the decisions. I'm saying that it's a partnership. And the doctors, it's really best to just play it very clean and honest and say, look, we don't know if this is going to work or not. This is what I do. I go from the safest options I can give people to the more dangerous options, because even for, let's say, for Bartonellosis, I was under this impression for a long time that the best treatments were rifampin, Bactrim, quinolones, which are statistically higher risk antibiotics than many of the others, and I can get a lot of patients better using safer options, and I present those options to the patients, and they kind of like the fact that there are safer options that they can try before undergoing, more dangerous therapies. And that's kind of the discussion that we have.
Thank you. I guess one question is when a patient is sort of faced with a reluctant clinician, right? They don't feel like they're getting the care that they want. What sort of strategies can they take to try to, basically get the care that they need? I mean, a lot of times, one example, to me, it's sort of bimodal. Oftentimes, the most important sort of few weeks of your life is right after you get a tick bite and you start feeling bad, right? If you go to a clinician that basically doesn't treat you, even by IDSA standards, immediately, that can lead to lifelong debilitation, right? So what sort of strategies? How does a patient communicate to their doctor to get the care that they think they need?
Well, I always encourage patients to follow their common sense. If they're feeling poorly after a tick exposure and their doctor refuses to treat them, and they have a long discussion, and I would say the person should seek out, care elsewhere. Frankly, I don't. You're not going to convince a doctor to keep saying no 4 times. You keep bringing it up, and they keep saying no, 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 and then time is a commodity also. You'll turn around, 6 weeks of arguing goes by, and you missed your window period for prophylactic or relatively prophylactic treatment. So I would get the opinion of several doctors and see what can be can occur that way.
Yeah, I mean, I think in that situation, and me and my family and I had to do this as well. It's on the patient, and that's what I meant too before when I said, it is all put on the patient's shoulders because we have this controversy, and when you have a doctor who's closed-minded and not willing to see the other side, the burden is on the patient, and now they have to go seek out care elsewhere, and they have to educate themselves. I mean, we basically suspected that Julia had Lyme disease through our own research, and we had to come to the discovery that there is a controversy in the field over Lyme disease, that two-tier testing isn't 100% reliable, that an LP is not 100% reliable, even though we were told it was. We had to come across this knowledge all on our own, and we had to seek out a Lyme literate doctor all on our own.
Sorry.
The panelists are disrupting themselves.
Sorry. I thought I silenced it.
But yeah, in this case, I would say it's on the patient to educate and seek elsewhere.
Okay. That's great. Thank you. And by the way, Dr. DeLaMora, the penalty for that will be a question.
That's fine.
Dr. DeLaMora, we know clinical diagnosis is king with Lyme since the blood tests are so poor. How often do you treat based on clinical symptoms in the absence? I'm assuming in the absence of a
It
test.
depends how long you've been ill for. So at least a few times a year. So again, let me put it to you this way. I don't see 50 patients a day with Lyme disease, okay? I'm mostly inpatient. On my outpatient side, which I see 1 or 2 clinics a week, maybe 80% of those patients will have Lyme disease or are concerned for Lyme disease or are worried about Lyme disease or a treater for Lyme disease. There's a very large variety of there. Most patients who are coming to me they're coming to me for a second or third opinion. I'm very rarely the first opinion for most of my children that I'm seeing. So I'm not generally seeing acutely ill, I have to make a decision right now kind of question. In the hospital side, we definitely every few weeks during the summer will see a child who's hospitalized with low platelets, low white count, petechia, can't find anything wrong. I don't care. I'm not going to wait for all your titers to come back. And the story that I always tell, and I think I told it to someone here before, is we don't always know all of the things that could be in a tick, right? So when you looked back when we first discovered Miyamoto, that was brand new to us, but when you looked back at banked blood from Block Island a few decades ago, it was there. We just didn't know. So those people were sent out being told there's nothing wrong with you. But there was. It just wasn't identifiable at that point in time. So if someone comes to me and they have a good exposure history and they're on the outpatient side and they don't really know what's wrong with them, you're getting some doxy. But we can give doxy down for everybody now. It was just, even though we've secretly been doing it under the age of 8 for quite some time because it crosses the blood-brain barrier, it's really good for central nervous system disease. We've now been approved to do it for everybody under the age of 8. But we do it. Not all the time, not as frequently as other providers in this room would. But I do think that it is something that I tell my medical students, you can't always look at those blood tests. They're not always going to be positive. And look at the C6. It's different for kids. What if they're immune compromised? And you can't make an antibody. There's a lot of things that go into that. So it's not something I do as often as other providers, but it's not off the table for me.
Great, thank you. So our panelists have been very engaging, which has limited the number of questions from the audience. You guys have just been intent on the information. So I'm asking a favor. Please go onto your phone. Focus. What? Going too slow. Going too slow?
Yeah, I'm sending you questions. I'll send you
Yes. My apologies to everyone. Sorry to insult you.
very active, but keep being active. I'll just go faster.
Okay. So I guess this might be a little bit controversial, but I was going to ask, oftentimes clinicians get blamed for kind of sticking to the IDSA guidelines and being much more restrictive on the treatments that they'll give. If a physician isn't interested in or doesn't use sort of more of their clinical judgment around that, can they be easily replaced by a robot?
I'm going to go with no. I think the other problem that I always explain, and again, there's a wide spectrum of beliefs, but the things that I think everyone can agree upon is a lot of our families are repeatedly exposed, right? They have houses up north, they have houses out east, they have houses down. So if you are someone who, every summer you go get your CBC and your cholesterol and your Lyme titer checked, and you were positive in 2016, and now you're coming to me in 2017, and you still have 7 bands, and you have headaches, and you're tired, you could have mono, but you could also have Lyme disease. Here's some doxycycline. It's very hard to tell that apart sometimes. But I do think if someone comes to me and says, it's positive, but not a thing has been wrong with me. I actually have less bands now, but my pediatrician sent me to you for this conversation. We're going to have a conversation about whether I give you medicine or not. I don't think a robot's going to have that conversation. I don't think robots should replace physicians.
I'm gonna go with yes.
You realize the career that you've chosen, right?
There, my friend.
I'm going to go with yes only because I think that if a doctor is textbook and a doctor is guideline driven, what's the point of having a human brain there?
Yeah. It's.
But are you? But I'm sorry because you're contradicting because you were trying to say, but you shouldn't be guideline driven necessarily. And you can find me on the internet saying they're not laws.
I guess what I was getting at is if you're guideline driven and you'll only do if someone has an EM rash, right, and has these very specific, restricted symptoms that you'll give them doxy, you can do that with a kiosk, right? Someone can just go in and punch in their symptoms and then give a blood test and then they'll be done. They can be on their way.
I don't think I understood your question properly then.
So we back to robots. You said that robots would be sufficient. When I say robot, I meant like basically a kiosk. Like you could just go in and use an iPad.
Like
would
we're
be
going
sufficient.
to CVS for this.
Yeah.
Oh.
Because essentially, a lot of times people feel like a clinician is a gateway to getting an antibiotic to help treat you right away, right?
But not all clinicians.
Well, not all clinicians. Yes, exactly.
That's what I'm saying.
Yeah. Not the good ones. I don't want to replace the good ones. There's a lot of good ones out in the audience. You guys aren't going to be replaced. So I guess one other question.
Can I just jump in and say one thing?
Yeah.
I think what's key here is to going to a Lyme literate medical doctor. I mean, that's the key.
Yep.
And the key, that's what we always say, as we have on our website. I mean, go to someone who knows about Lyme disease. I mean, don't stay with your primary care physician. I mean, let's go to someone, if you suspect Lyme disease, go to someone who knows and knows what to look for and can do the clinical diagnosis, can do the blood tests, can give antibiotics if they suspect ahead of time before waiting even for the test to come back. Every physician has a different comfort level with that. But I think the key is jumpstart. I mean, get out of that, guideline, this, that. No. Let's get to someone who can help you. I mean, that's the key.
Yeah.
I mean, to me, go to someone who really understands Lyme disease.
But the next discussion after that is limited access to care. I mean, my personal waiting list just for myself was 2 years. And then I closed it 2 years ago, and it just went through that waiting list. And I may open it again, I don't know. But so it would be great. In a perfect world, we would educate all the doctors about the reality of this wide spectrum of illness. Miyamoto is one example. At least they do have a test for that. There are Borrelia species they have no test for. Bisetae, Mayonnae, Lone Starry. What do these people do? There are no tests anywhere. You can't send that to any academic center. And I just think that we have to understand that this is an enlarging spectrum of illness, that they knew about one Bartonella species in the 90s, and they've discovered like 45 species since then. These are emerging infectious diseases, and for any doctor to think that the book is written on this complex of illnesses is so short-sighted as to be almost laughable. So just that bit of education, even to educate doctors that we don't know everything, like not to speak with certainty, that's a valuable teaching point. Don't be so certain. So I went to a business program before I went to med school. I went to Wharton, and then I went to med school. And it was a completely different training. Wharton was just one big IQ test. Everything was risk-benefit ratio and net present value. And med school was memorization. And basically memorization only. They don't teach you to think critically in med school like they do to teach you, they teach you to think in these other kinds of programs. And I think that's lacking. We want to be problem solvers. We don't want to be kiosks. We don't want to be robots. So whatever you guys, if anybody has pull on, teaching some med students, that's where it's at. We got to change how doctors are trained.
I think that's an important point. Taking a question here. how do you get, knowing that a lot of times the testing is somewhat unreliable in certain circumstances, how do you guys incorporate that into your diagnostic protocol?
Well, for me, it's a large protocol, but I don't just focus on serologies. So we check for, serologies for a number of zoonoses, and for example, like Anaplasma ehrlichia, they don't really cause chronic illness in humans, but positivity to that will raise the risk of exposure to other, vector-borne illness, and that's just like something that changes your kind of suspicion profile. In terms of clinical diagnosis, there's a whole symptom list, and you're looking for a multi-system kind of presentation, but there are also immunologic and inflammatory markers like the wake of what these infections can do that are somewhat specific for Bartonella versus Lyme and what have you. Without getting too technical, for example, they have different preponderances to different degrees of hemolysis, with Bartonella and Babesia causing more breakdown of red blood cells than Lyme does. And Bartonella frequently causes, cytopenias, so low counts, like low white count chronically is very suspicious of Bartonella. Lyme typically doesn't raise C-reactive proteins. Bartonella can in about half the patients. Markers like vascular endothelial growth factor. So there are a number of kind of surrogate markers for these infections that we also follow. And there are some specific clinical features that I've come to recognize in Bartonella patients that don't really occur in Lyme, like breakaway weakness, where the legs buckle out from under you and people are dropping glasses, things like this. And the corollary to that is myoclonus. So it's a complex kind of a thought process that we go through, and a lot of this stuff has been published, and some of it's just things I've seen over time.
This is going to slightly break away from the patient provider partnership, but we don't have this topic in the session today, so I figured I would ask it because it's a question. It's for Phyllis, but Dr. DeLaMora, you can also chime in. Do you see any congenital Lyme in your applications?
Oh, yes. So we have whole families. My family is one. But we have a large percentage of our grant population that are families. Generally what happens is one child comes, and in the application they'll mention that there's perhaps another sick child and or a sick parent. And this is rising. I mean, it used to be, when we first started, it was just a child. And then now I would say we're probably up to 40%, maybe even 50%. That's entire families. So, common sense would say that not all these people were bit at this, in their backyard. It's, like I said, even from my own family. Congenital Lyme is out there. It's something we need to talk about. I'm just waiting till we can all be very vocal about this, because there's a whole lot of people that are getting infected that have no idea they're getting infected this way. So that's my personal feeling and my personal pitch.
I also see families where everyone is diagnosed with Lyme. However, I don't think the science supports that it's congenitally transferred. I think I know I'm going to get some bumbling over here, but I get this question pretty often in my newborns in our nursery. Can the mom breastfeed? Is it transmissible? I know that guidelines were updated last year. I know that's not going to be a popular opinion in this room, but the regularity of moms always giving babies Lyme disease, if the mom was properly treated, I have not seen evidence that this is a very, very common phenomenon in a treated mother.
I think this just bodes, both can be right here. I think that really it's education, and there needs to be more out there about it. Because, for example, I didn't even know I had Lyme when I was pregnant. And, it's so funny how you get one person in a family sick, and then it's sort of like a beacon of light. Then you all of a sudden look at everyone else in the family and go, oh, this is what's going on. And I think there does have to be more testing, certainly. But it's sort of the thing that none of us really talk about, right? How much do we say about it? But I think
I get called for it all the time.
Yeah.
So it's hard to test because, unfortunately, we have this crappy antibody test, right? And any baby who's born after 32 weeks is going to get their mom's antibodies. So any antibody you find in a baby is mom's. You can't, if you're looking for IgM, which does not cross placenta, in a baby, I'm not sure how much I would think about the reliability of that. But if you're looking at placenta, and you're looking at, and that's how we diagnose virtually every other congenital infection by looking at placentas, there's not a lot of evidence of it in a treated mom. So, and that's been a change over the last 2 decades, that the concern, as we have more information and you look at the published literature, it doesn't support a very high burden of congenital Lyme. That being said, if you have a kid who is 8 and mom tells me that she's been off since she was 2 and the whole family's been diagnosed, there is a propensity to wonder, right? But you can't prove it. So if you're looking at the actual newborns,
Maybe
though,
not
it becomes
yet.
questionable. Right. So we need, again, this circles back to we need antigen-based testing rather than antibody-based testing, which Cornell is working on.
Go Cornell.
Yes.
I think there are a few published case reports of children who are, stillborn, where they've isolated, they found actually Burgdorferi in the tissues themselves. I can just tell you personally, I don't see children, but I see lots of moms who have given birth, and some have been treated through their pregnancy, and many have not. And I've seen a number of cases of foreskin and cord blood PCR positive for both Lyme and Bartonella.
So I'm not saying this is a never event.
No, I know.
Okay, okay.
How common is it? Right?
Yeah.
How common is it? I have a very, very good track record in treating patients throughout their pregnancy. I've only seen one case where the foreskin and the cord blood was positive for Lyme and Bartonella in somebody who's been treated throughout the pregnancy. So.
Yeah, I think this kind of goes back to some of the issues we talked about earlier of needing additional research around these areas to help the clinicians. So I don't know if any of the researchers out there are listening, but something to think about. Another question on treating kids with Bartonella and Babesia.
Yes. Yes, I do that.
Okay, can you elaborate a little bit on that?
We had a child who came into us with fever for a month with liver and spleen lesions, hospitalized, low count, everything, big workup. And all of us are sitting around the table listening to our resident present this, and all of us looked at each other and said, this kid has bacillary angiomatosis. That's what this is. And another attending at the table was like, psh. And the kid had raging Bartonella and is getting better. Babesia, again, for reasons that aren't quite clear, who gets Lyme disease in the United States? 5 to 10-year-old boys, of which I'm the mother of one, and older middle-aged men, so people who are spending their time outside, apparently. But the rates of the co-infections in children, for reasons that are not clear, same tick, same attachment, right? We don't see it as much. We check for it, send off our PCRs and our smears and all the other stuff. Don't see it a ton. Not as much as it seems to be seen in the adult population. And I'm not even talking about the borderline antibodies, yes or no. It's very often, we send it because the child is well, but the parent is concerned that there might have been a missed co-infection and the doxy wasn't sufficient, which I agree. So then we'll send it, and it's just a no. And the child is fine. We're sending it, just for completeness sake. I don't know why, but if it's there, we'll treat it. Yes, it's a thing. Let's not pretend.
Do you use fish testing for Babesia?
Nope. I use PCR. It's more sensitive.
Great. It actually came up a few times in the questions. Just to get a little perspective on the physician's sort of mindset, do you guys ever feel that basically your licenses are in jeopardy when you're treating Lyme or other tick-borne diseases?
No. No one's reading my charts. No one's looking to see what I'm doing. No one's looking to monitor what antibiotics I'm giving to whom. If I'm hired there as faculty, I'm trusted to do as I see clinically relevant. So if I, veer off course, no one calls me up and says, I just read your chart, what are you doing? No one says that to me. I may get some eyebrows from our neurologist every once in a while when I ask them to do an LP, but they do. And no one's double checking my medical practice.
I think for many Lyme doctors, especially in New York, there has been a lot of scrutiny and a lot of problems that the doctors have gone through. In Connecticut, it's been a more friendly environment for a long time, but there have been some, and fortunately I have not been one of them. But my grandfather, may rest in peace, used to say, punch a bully in the nose all the time, and I just keep punching bullies in the nose. So, I think that they go after the ones that are kind of quiet, and I've not been quiet at all, and have testified at the state level in Connecticut multiple times, and testified in Rhode Island and Vermont. And, I bring to the table the data that documents the chronicity and the reality of what's going on with these infections. And, every time these kind of divergent views, they always send IDSA representatives to these meetings, and they present their data, and I present the data about chronic infection. And then they end up passing a law protecting Lyme patients' rights and furthering the rights of physicians to treat Lyme. And you could say what you want about politics, but these are legislators that listen as fairly as they can to both sides of the story, and they decide that the science is in favor of, wait a second, this is a difficult to treat infection. These people need to be protected. And I always say that if the politicians can figure it out, how come the doctors can't figure it out? I always say that, if you want a good, neutral opinion about Lyme, ask your plumber, don't ask your doctor, because, you're going to get an unbiased view. Doctors will come to the table with a preformed, story of what Lyme is or isn't. And anyway, so I have not had problems, but it's in the back of your mind that they can come after you at any time just for trying to do the best you're doing to help people. And it's a really kind of sad commentary.
Another question from the audience, and I'm sort of paraphrasing with my own thoughts on this. You had mentioned earlier there's a lot of trial and error oftentimes, and I think both from a clinician side, but even as Samantha was saying on the patient side, you're going through a lot of different options, right, all the time. And if something didn't work after a few months, you go to something else, right? How are we all communicating about that? Are Lyme doctors communicating with each other about what's been working, what hasn't been working? Are there options for patients to be communicating on that same vein? I mean, we've all been on sort of the blogs and stuff like that, which is an overload of information. But what's out there? Have you guys had any other sort of experiences that you guys can share?
I mean, there's medical conferences all over now for Lyme conferences. ILADS has a large yearly conference, and whenever we get together, we talk about our experiences, but there's no centralized database, like a large data mining kind of a thing, about if there's a way to put this to an algorithm. I've tried to make algorithms in my practice, and they work-ish. I mean, every patient has to be so individualized that you just kind of throw the algorithm out the window. So I don't really know how to answer your question. I think that the internet, the exchange of information that way, the exchange of information at medical conferences, and just calling other doctors that we know on the phone. But I don't know. There's not many summits where you just brainstorm on how the best way to do it. Maybe that's something that we should be doing.
Phyllis?
I just want to say, I think patients share with patients. And that's hugely impactful. In the Lyme doctor waiting rooms, some of the best sharing occurs, and in the IV lounges. And it's amazing, again, you get a bunch of empowered patients together, and they share with one another. It's amazing. You want to know some of the smartest people, go into a Lyme waiting room. And honestly, I mean, I'm so impressed with these young moms who are taking care of their kids and they're sharing with each other. That is hugely helpful because you learn something, then you go home and research it, talk to your doctor about it, talk about it, is it right for you? That's hugely impactful. We have, for our grant recipients, we have a private Facebook group that we do monitor, but we talk about, share amongst yourselves. Again, Lyme is so isolating. The more that you can share with one another is really impactful. So I think since it is such an individual and a patient-led process and partnership, that it's up to the patient really to become somewhat educated and involved themselves. And that's honestly, I don't know if you found that.
Yeah, no, I completely agree. That's where I learned everything that I know is from these offices. As a patient, I was never up to going to any conferences. I couldn't sit there. I couldn't listen to what was being said. So the only way that I learned anything, I couldn't read, I couldn't focus on anything, was sitting in these doctors' offices. It was the only time I ever left the house. And talking to people, they have such a tremendous wealth of knowledge, and that I think really needs to be tapped into.
I think, Kristen, honey, where are you? There was a whole group that was formed in your IV lounge, the Spira Chicks. Yep. There's a whole group of very dynamic women that all go back to that one IV place. So it's amazing what can happen.
Yeah, and I agree with that too. I think that since my sister has been sick and was blessed by the Pope and received like publicity, I mean, over the past 3 years, hundreds of patients have reached out to my family, my father, over social media, desperate for help because, you know, they're in the situation we were in at the beginning. They don't know where to go. They are alone. They don't have the energy to get out of the house and go to a doctor or go try 50 doctors, and I think that that's really useful for patients to share because we get to tell patients what we took a while to learn ourselves at the beginning so that they could, take charge of their health.
Well, great. I just want to thank you guys so much for sharing your stories, sharing your knowledge, and really being open and providing a great resource for everyone here. So we can all a round of applause for you guys. And I think I'm kicking it over to Savi for the next session.